Good evening. Today we will be discussing a very important topic, which is coronary revascularization in events of acute coronary syndrome such as STEMI, NSTEMI, unstable angina, etc. First of all, we have uh, several options to go ahead with. The PCI or percutaneous coronary intervention. It's commonly used in acute MIs for patients who present with STEMI or sometimes in STEMIs too. In percutaneous coronary intervention, we use a catheter, and then it's a minimally invasive procedure to place a stent in the area of obstruction and open the obstruction. Coronary artery bypass, it's a major surgery. It's open heart surgery. We do sternotomy and then go and bypass the area of blockage by putting a new graft. We used to do balloon angioplasty, which was kind of dilating the vessel directly, and now it's not used alone. We use it either with a PCI or another procedure to have better effects. Finally, some patients may benefit from a combined procedure in which we do PCI plus cabbage. Um, this is way advanced in the level of this class, so we will not be discussing this in details, but some patients may qualify for a cabbage plus a PCI, and they have better outcomes compared to a cabbage or a PCI alone. Now, first, balloon angioplasty. It is a method that we used to use a lot, but nowadays it's getting used less often. What we did was put in a catheter to the area of blockage and try to compress the plaque with the catheter by dilating the balloon. And this way we open the circulation back to the heart. Um, it has some advantages. It's low cost. Reperfusion is quick, and we are not leaving any foreign body inside. It's still used in some countries, but in Canada, USA, etc., it's not used alone right now. Because it has high risk of restenosis due to vessel recoil. Nowadays, in modern or advanced countries, it is used for stenting just temporarily for patients who are a good candidate for cabbage but are not in a good condition to be undergo cabbage or open heart surgery. So we use it as a bridge for those patients who need cabbage and they are in STEMI. We just want to provide reperfusion so that the myocardium doesn't die, and we get some time to do cabbage for them. Percutaneous coronary intervention, this is the second method. It's nowadays used widely. Most countries use it. The goal is to get this done within the 90 minutes window when the patient arrives at the door, from that to the balloon or when we start doing the PCI itself. It's also catheter based. So what we do is we dilate the area and leave a stent there. That's pretty much PCI. Its advantage, again, it's minimally invasive. Patients recover quickly, and procedural stroke risk is lower in PCIs compared to balloon angioplasty. Disadvantage, it also gets restenosis at a higher rate, and in most more patient with PCI may need a repeat procedure compared to cabbage. Now, when is PCI the best option to do? If it is a one or two vessel disease, patients who are high risk surgical candidates, and in acute MIs, because we do not have time to prepare a patient for a cabbage, so we can do PCI. It's quick, easy, and minimally invasive. Third option, coronary artery bypass grafting. We surgically use a vein or artery, usually from the leg, and place it in the area where we have a blockage. So we just bypass the blockage. Advantage is that it is superior. Long-term patency or long-term staying open is superior in cabbage compared to PCI, and it's better option for left anterior disease. and it allows complete revascularization. Even if there are 3 or 4 vessel block, we can bypass all of them. Um, Biggest disadvantage is that it is very invasive and it has a high risk of stroke during or around the operative time, and it takes a long time to recover. Some patients take weeks to be able to walk again after getting a cabbage. Now, who is this ideal for? People with 3 vessel or more vessel disease, people who have left main coronary artery disease, patients with complex anatomies which cannot be accessed through PCIs, and patients with diabetes. So remember, a diabetic with 3 vessel disease is the ideal candidate to undergo CABG or CABG or coronary artery bypass grafting. Now here's some comparison between PCI and CABG. First factor or thing to consider is how invasive each is. PCI is minimally invasive. CABG, it's very invasive. You have to do sternotomy in order to get access, and recovery time is also low in PCI, but in CABG it's very high, weeks to months. Perioperative stroke, it's up to 1% in PCI, but in CABG it can go all the way to 2%. The advantage of cabbage is that it has low risk of repeat revascularization or revascular intervention. And in cabbage, spontaneous MIs or MIs after the procedure, they are at a lower rate compared to a PCI. Now, why we prefer cabbage over PCI for left main coronary artery disease? Uh, there were some trials done. Most important is this Excel/Nobel trials, and they found that cabbage is superior for left main disease versus PCI. But PCI is also acceptable if patient refuses cabbage. Cabbage is contraindicated for other reasons, or patient's anatomy is suitable for a PCI. Another risk or another factor is that if patient has diabetes and left main coronary disease, PCI has significantly higher mortality than a cabbage. And in multi-vessel disease, cabbage is superior long-term compared to a PCI. Stents, we discussed yesterday, there are 2 types of stents, bare metal and drug-eluting. So bare metal stents, they are made from stainless steel mesh and they do not have any coating of medication. They have advantages, which are lower risk of thrombosis, shorter duration of dual antiplatelet therapy. You need dual antiplatelet therapy for 1 month, and then patient can take aspirin only for lifelong. The disadvantages are that the bare metal stents, they have a higher risk of restenosis due to proliferation and vessel recoil, and they're used for patients who are unable to tolerate long-term dual antiplatelet therapy, or sometimes in emergency settings when DAS or drug-eluting stents are not available. Patients who cannot tolerate dual antiplatelet therapy are patients who are high risk for bleeding, etc., or patients who cannot take aspirin due to GI bleeds, etc. In those cases, we can consider a bare metal stent instead of a drug-eluting. Now, drug-eluting stents, they are a stent, which is a stent platform. There is a polymer coating, and then there is a drug that prevents that proliferation. That's how it stops the restenosis from the early restenosis from occurring, and it has low restenosis risk compared to a bare metal, and it has long-term better outcomes than a bare metal stent. Disadvantage is that uh, thrombosis risk is higher in it, especially later on. That's why they need dual antiplatelet therapy for 12 months and then aspirin monotherapy forever. When do we use drug-eluting stents? For high-risk lesions, patients with diabetes who cannot undergo cabbage, patients with multiple vessel disease, left anterior or left main coronary artery if cabbage is contraindicated. Now, these are some types of drug-eluting stents. Sirolimus is one, paclitaxel, everolimus, zotariolimus, biolimus. These are all different generations of or types of the anti-proliferative agents or the medications used to stop the proliferation of smooth muscle around the stent. Now, DES or drug-eluting stents, they have a polymer coating. They have several types of polymer coating. These are the different types. You don't need to know it. It's for cardiology residents, not for someone who's taking NCCQ-E1. But just one thing is that the newer generation of drug-eluting stents, they are uh, safer compared to first generation ones. So here, if we come back, the sirolimus, which is a first generation, and then it has a durable polymer with it, it's not as safe as compared to this everolimus, which is a newer generation of the DES. That's why nowadays you would see these newer ones being used more often than the older ones or the first generation ones. Now, when do we use drug-eluting stents, or and when do we prefer bare metal stents? For patients with diabetes, we use DES. Patients who cannot tolerate dual antiplatelet therapy, we use bare metal stents. For small vessels, less than 2.5 millimeter, drug-eluting is better. Left anterior disease, left main disease, drug-eluting is better. Lesions that are longer in length or lengthier, we use a drug-eluting one, and multivessel disease, again, drug-eluting stent is preferred. Uh, Bare metal stents, if someone is undergoing a life-threatening surgery, or if we need to urgently save someone's from myocardium and we don't have availability of DES, we will use bare metal. Patients who have very high risk of bleeding, they undergo bare metal because you need shorter duration of dual antiplatelet therapy. In emergency situations, you can do a bare metal stent, and patients who have short life expectancy, you can consider a bare metal stent so that they don't have to take multiple medications at once. Now, three vessels disease, PCI or cabbage, which one is preferred? Cabbage has superior outcomes. Centex score, this considers age and comorbidities, etc. And this Centex score, it helps in determining if we can do PCI for someone safely or if we should consider cabbage. Um, if someone has low Centex score, usually less than 22, you can do PCI for them. It has the same amount of benefit or similar benefit or outcomes compared to a cabbage. But patients with high Centex, usually those who have diabetes or other comorbidities, cabbage is superior, especially if they have diabetes. Um, at the end of the day, it's discussion between the whole cardiology team for each patient's decision making. They will do a quick meet and decide whether to do PCI or cabbage or medical management. How long we do dual antiplatelet therapy by stent type? For bare metal stents, 1 month. Aspirin plus clopidogrel, ticagrelor, P2Y12 inhibitor. For drug-eluting stent, we do 12 months of dual antiplatelet therapy. Patients who are high bleeding risk and we want to do DAS, we can use a newer generation of drug-eluting stents and then do dual antiplatelet therapy for 3 or 6 months. Note, aspirin is indefinitely. P2Y12, like ticagrelor, etc., they are used for this duration, 1 month, 12 month, 3 or 6 months. All right. Um, when to choose each, this is a quick decision making algorithm. PCI is preferred if it is acute MI, one or two vessels are affected, patient has high surgical risk, and severe left ventricular dysfunction is present. Cabbage, if there are three vessels or more vessels, left main disease, diabetes, complex anatomy. In those cases, we would do cabbage, not PCI. Okay, I think that's all for revascularization. If there are any questions, please let